Welcome to the Johns Hopkins Medicine online webinar series. Today, our experts will be speaking about congenital diaphragmatic hernia, caring for you and your baby from prenatal diagnosis to infancy. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your email address will not be shared with any third parties, and we will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Ahmet Baschat to begin our presentation. You're muted, Dr. Baschat.
Thank you very much. So I'm the director of the Johns Hopkins Center for Fetal Therapy, where we do the prenatal assessments of patients with a prenatal diagnosis. So congenital diaphragmatic hernia for the prenatal diagnostician is a condition where we have to consider the severity of the primary defect. So the issue is basically that there is an opening in the diaphragm that allows a variable proportion of abdominal contents to end up in the chest of the fetus. And what that does is it compresses the lungs to a variable degree during phases that are critical for normal lung development. And while the baby doesn't need the lungs in fetal life to breathe because the placenta takes care of that, when the baby is born, there is various degrees of respiratory impairment that are basically proportional to how big the defect is and how much the lungs are compressed. Now, the other thing that's important is at least 10 to 15% of babies with prenatally diagnosed diaphragmatic hernia also have genetic abnormalities or other conditions that add other considerations for the postnatal care for the baby, or genetic abnormalities that cause the defect in the first place, and other organ systems affected, first and foremost congenital heart defects, as well as other lung lesions. So our prenatal goal is to make the prenatal diagnosis and then also give the parents with an estimate of the severity of the defect as it pertains to the lung function, and also look at if there's any other additional anomalies that require specialized management. Our ability to sort of predict the severity in lung compression is ultrasound based, and there's a measurement that's called the observed to expected lung to head ratio, which in very simple term can be sort of expressed as the percentage of lung size. So if a normal lung is 100%, if it's only 50%, it's half compressed, and so on and so forth. And the lung that we look at is on the other side of the hernia. So if we have a left-sided congenital diaphragmatic hernia, like in this top image here, it is the right lung that we measure. And there is a direct relationship with the observed to expected lung to head ratio and the severity of the hernia as it pertains to survival. And this is what we use prenatally to say from the anatomic defect, we are subdividing this into a mild, moderate, or severe congenital diaphragmatic hernia. And clinically, after delivery, the severe hernias, they basically go together with those larger defects that are classified as C or D, where a big portion of the diaphragm is missing. So mild diaphragmatic hernias may not be diagnosed early on in pregnancy because they don't produce this displacement of the normal structures in the thorax, but most severe hernias and moderate hernias are in fact diagnosable by 18 to 22 weeks and sometimes even earlier. So that allows us to give the parents counseling early on. I wanted to briefly go into fetal therapy because that's congenital diaphragmatic hernia is a fetal condition where there has been recently advances in research in a randomized trial that was published in how we can improve the survival in babies, specifically with severe hernia. There have been some observations from other conditions that when you block the fetal trachea and the lung fluid cannot escape, it actually reverses some of the compression effects. And we achieved that prenatally by deploying a latex balloon into the trachea of the fetus for a period of about 6 weeks, and where we then observe that the baby's lung size actually grows. There was a large trial that was initially done to look at this, how this should be performed. So typically it is done in babies with severe congenital diaphragmatic hernias. They're basically about 30% lung size. The balloon is inserted at 27 weeks, and here is sort of a clip that we also have on our fetal therapy website, where we place a fetoscope, which is about a 1.3 millimeter camera, through the mouth of the baby and follow the landmarks in the mouth all the way to the back of the throat, then find the entrance to the trachea, where we then insert the tracheal occlusion balloon. And this is basically done in babies where we know it's an isolated congenital diaphragmatic hernia. That means there are no other physical abnormalities diagnosed at the time, and the baby's genetic testing is normal. The technique in the US is available only under an IDE approval from the Food and Drug Association, and there are only a handful of centers in the country that are able to offer this procedure, and Johns Hopkins is one of those centers. And basically here we show the entry into the fetal trachea, where the balloon will be deployed in a minute, and that stays in place. When we do serial ultrasounds, we can actually observe that the lung size on average doubles in the 6 weeks following the balloon insertion, and then the balloon needs to be removed so that the baby can actually take a breath after delivery. And after that, we see somewhat a decrease in lung size, but overall we are likely to convert a severe hernia from a size more to a moderate size hernia. And in the initial studies, it has initially been shown that the survival is likely to be doubled, and most recently there was a randomized controlled trial that looked at the fetal therapy in severe hernias and moderate hernias, and basically documented a significant improvement in survival for the severe hernias, whereas in moderate hernias the benefit of a balloon was not as statistically significant. And that's primarily because there's some risks of preterm birth, and where some babies basically suffer from being born too early after these procedures, but for babies with severe hernia, this showed a benefit. So this is something that was published in May of last year and received a lot of attention. And although there's a statistical significance in difference in survival, there are also some significant differences in the care of CDH patients in the US compared to Europe, where this total trial was done. And so generally, I'm happy to say we can tell our patients that in centers where you have integrated CDH programs, the survival without fetal therapy in the US is significantly higher compared to what was found in the total trial. And when we look at publications from US centers, that includes Hopkins as well as Baylor, we have a higher percentage of babies that benefit from ECMO treatment. We can take all of our babies to successful surgical repair, and there's comparable lung function at discharge, but significantly higher overall survival. And so the numbers overall, and my colleagues are going to go into this in some more details, are overall more reassuring or encouraging. Now, why is that? So diaphragmatic hernia is a condition where, when you do prenatal diagnosis and you do fetal interventions, the management isn't over with just fetal care. It actually, the definitive treatment is after delivery, and it's by our pediatric colleagues, and the management basically does not really end, after the baby is born, like for some other fetal conditions. And so one of the things that is important in the US, so balloons are only offered at centers where there is a fetal therapy program that works hand in hand with an experienced CDH program. And in a sort of preliminary study where we compared sort of the outcomes when you look at sort of the US type of integrated management, where you do prenatal diagnosis and plan the care transition and delivery into a CDH program at the same institution, that has a significant impact independently on survival. And we've a follow-up analysis that we've done with our colleagues, with Dr. Kunisaki, that is a larger follow-up study that confirms these studies. So integration of care is exceedingly important for congenital diaphragmatic hernia. So our prenatal perspective is, from a diagnostic perspective, are there any additional anomalies? Are there genetic abnormalities? What is the severity of the hernia? Are patients interested or candidates for fetal therapy, which we can fortunately offer? And then we prepare our parents prenatally by consulting with all the relevant pediatric specialties that are going to take over the care and complete the care of the baby after birth, and then establish the prenatal care so that we can plan a coordinated delivery at our institution. And with that, I'd like to turn over to my next speaker. Thank you.
Yes, hi, good evening, everyone. My name is Dr. Alejandro Garcia, and I'm one of the pediatric surgeons here at the Johns Hopkins Children's Center. And I'm also one of the surgical directors for our pediatric ECMO program. So now that you've heard a little bit about the fetal management, I wanted to discuss what you would expect after your child is born with the CDH. So after your child is born, they'll be immediately assessed by the neonatal intensive care team, and a breathing tube is placed immediately. The patient is brought to the NICU right away, where they can be assessed by our full CDH team. While your child is in the ICU, they'll be assessed not only by the neonatologist, as well as the cardiologist, pediatric surgery team, as well as the pulmonary hypertension team. One of the first few things we do after the child is born is obviously to assess how well their heart and lungs are doing and whether or not they would require ECMO. So initially, your child will be supported on a ventilator, as you can see in this picture. Your child will also receive special IVs, which are placed by the neonatologist in the baby's umbilical cord to allow access to the baby's blood pressure, as well as to be able to draw blood and give medications. Following this, our cardiology colleagues will come and do an echocardiogram, where they'll make an initial assessment about how the baby's heart is doing, as well as to make sure that there are no other defects that may require other interventions. And we continue to work, the pediatric surgeons, the cardiologists, with the neonatologists to make sure that the baby is optimized and doing well. If the baby's lungs continue to have issues related to their ability to get enough oxygen in their blood, the neonatologists may sometimes advance the amount of ventilation that's required, and they will use something called an oscillator, which is pictured here. And the oscillator provides the ability to give hundreds of tiny little breaths to the lung to help protect the lung and prevent any damage that may occur from the ventilator to the baby's very fragile lungs. As I mentioned, we get an ultrasound of the patient's heart, which is an echocardiogram, to see if there's any pulmonary hypertension, which is stress to the right side of the heart, as well as any other defects. And part of what you'll see is that we'll offer different medications to see if we can help improve some of the functioning of the heart, as well as the lungs. This is a picture of nitric oxide, which is a gas that we deliver through the ventilator to see if we can help dilate the arteries in the lungs and provide better oxygen for the baby. So this is also part of an armamentarium of different medications that we will offer to make sure that we can optimize things for the baby. Unfortunately, if the lungs or the heart continue to be stressed and go beyond our limitations of what we can offer, then we would offer ECMO, which is a heart-lung bypass machine that you can see here in this picture. And this will provide an opportunity for us to be able to rest the heart and the lungs while we continue to support your baby through this process. To be able to place your child on ECMO, we do a small procedure or surgery within the NICU, and we make a little small incision in the child's right neck, and we access the main artery and vein going down to the heart. And we place these cannulas, which are large IVs, into the artery and the vein, down to the heart, and those we attach to the ECMO circuit, and that allows us to be able to draw blood, provide oxygen, be able to give medications, and deliver the blood back to the baby, while at the same time allowing the heart and lungs to recover. As I mentioned, ECMO, although being a procedure, it allows the heart and lungs to recover while we take the child through the next step of the process, which is surgery, which my partner, Dr. Kunisaki, will go into more detail. Now, ECMO does require a procedure, as I mentioned. It also does require that your baby be on a blood thinner to help prevent clotting that can occur within the ECMO circuit. Because of this, we will be getting daily ultrasounds of your child's head to make sure that there's no evidence of any bleeding, so we can continue to perform the ECMO safely. And I just briefly wanted to talk about ECMO at Johns Hopkins Children's Center. About 43% of patients will ultimately require ECMO, and this is particularly in the severe CDH population. The average duration that patients will need ECMO is about 9 days at our center. And the average time that patients require time before they go to the operating room to have their hernia repaired is about 7 days. And most babies will be intubated for about 25 days if we look at all our patients. Thank you.
Thank you, and good evening, everyone, at least from the East Coast. My name is Dr. Shaun Kunisaki, and I'm one of the pediatric surgeons here at Johns Hopkins in Baltimore. As surgical director of the CDH program, I work closely with Dr. Baschat and the other fetal therapy physicians and do most of the prenatal counseling, sharing my surgical perspective on CDH treatment. In this session, I will build on the presentation on the ventilator and use of ECMO that you just heard by Dr. Garcia and give you an overview of the surgical management of CDH here at the Children's Center. Next slide. I have no disclosures. Building on what Dr. Baschat said earlier with regards to CDH program integration before and after birth, our philosophy really has been that a care approach that includes an experienced multidisciplinary team of physicians and nurses working in a coordinated fashion together within a world-class medical institution is really essential to get the best possible outcomes in the CDH child. Next slide. So at the Johns Hopkins Children's Center, we do take this team approach to deliver an individualized care plan on how we repair the diaphragm in any newborn with CDH. It's not a one-size-fits-all process. And one important factor in surgical decision-making is disease severity, which really has a wide clinical spectrum, as Dr. Baschat has already alluded to. On one end of the spectrum, there are babies who barely need any ventilator support at birth. To the other end of the spectrum, with an unstable child whose lungs are really not working at all at delivery and need emergent ECMO cannulation within the first few hours of life to avoid death. Much of this can be predicted with high accuracy when the baby is still in the womb. But we also confirm our suspicions about disease severity at the bedside, working with our neonatologists and through echocardiograms and other studies during the hospitalization. Next slide. There are two main operative approaches, namely thoracoscopic surgery, also known as keyhole surgery, and traditional open surgery through an abdominal incision just below the bottom of the rib cage. In babies with more mild lung disease, as indicated by low ventilator settings, the keyhole surgical approach through the chest is ideal, since smaller defects can be easily repaired using this technique and with smaller scars and less pain for the baby. However, in babies with more severe lung disease, as indicated by higher ventilator settings, the open abdominal incision is better as it allows the surgeon to better restore all of the organs back into their normal location, and the surgeon can more easily sew a large patch to cover the defect if needed. Next slide. CDH babies with less severe lung disease are on lower ventilator settings and generally have smaller diaphragmatic hernias shown here in the red box. On the other hand, CDH babies with more severe lung disease require higher ventilator settings and generally have larger diaphragmatic hernias shown here in the blue box. These children, including those who require ECMO support, often require a large synthetic patch to create a barrier between the chest and abdominal compartments so that reherniation does not occur. Next slide. This is an intraoperative photograph showing an example of a medium-sized diaphragmatic hernia repaired with a synthetic patch. Next slide. It's important to understand that diaphragmatic repair is not an emergency procedure once a CDH neonate is born. While most surgeons believe that early diaphragmatic repair does offer some benefits, it is more critical to perform the operation when the baby is stable enough to withstand the anesthesia and the 2 to 3 hours of the operation itself. Most diaphragms can be repaired within the first week of birth. And the timing of diaphragmatic repair for patients requiring ECMO remains somewhat controversial. Nonetheless, we believe that early repair while on ECMO support can be done rather with low complications and really gives the best chance for a good outcome. Next slide. Giving breast milk or formula to a CDH newborn before the diaphragm is repaired is generally not safe. So in the meantime, nutritional support of CDH babies occurs by giving calories through a special IV called a PICC line. The intravenous solution is also known as total parenteral nutrition or TPN. Once the intestines recover after surgical repair, babies can be given breast milk or formula based on family choice. But it's important to understand that many CDH infants do have pretty substantial gastroesophageal reflux, so spit-ups and vomiting are quite common early on. We do work closely with the NICU team as well as other feeding providers to make sure your baby grows and gains weight normally during this very critical time in development. Next slide. It's also important to understand that even after surgical repair, the lungs are still small and fragile, but these lungs will grow and get stronger over the ensuing weeks to months, and with appropriate medical therapies under the guidance of our NICU team, in conjunction with input from our pulmonary and cardiology colleagues. Once the breathing tube is removed, it is safe for mom and dad to hold the baby. And at that point, we work diligently with our expert multidisciplinary team to wean all pain medications and remaining oxygen support. The use of inhaler medications as well as drugs to treat pulmonary hypertension is quite common, but by discharge, most CDH babies are off supplemental oxygen therapy and are swallowing breast milk or formula, although sometimes a feeding tube is necessary to ensure maximal nutritional support. Next slide. Our overall survival rate to discharge at Johns Hopkins was recently reviewed, and it's 83%. Which places us in the top tier nationally in terms of outcomes, survival outcomes, and is well above the national survival rate. I think this is particularly impressive given that our program treats disproportionately more babies with more severe lung disease because of our fetal balloon program. We also have to remember that many of these children were originally referred to us and not really given much hope for survival. And our survival rate in CDH babies who do not require ECMO at all is 97%. Although I've certainly seen kids leave the hospital in 2 to 3 weeks after being born, most CDH babies are hospitalized for considerably longer periods of time, more on the order of 2 to 3 months. Because CDH babies really can have a wide range of chronic problems due to their underlying lung disease, and for being so sick, we do work diligently with families even after discharge through our multidisciplinary CDH clinic, where a team of doctors and other specialists can see and evaluate your child at the same time. I think more on this amazing resource next from Dr. Nies, our CDH cardiologist. This concludes my segment on the surgical management of CDH. Thank you very much for your time.
Hi, everyone. Thanks for coming. I'm Dr. Nies, Melanie Nies. I am the pediatric cardiologist in the CDH group, and I'm also the director of the Echo Lab here at Johns Hopkins. So I get a fun part of this webinar. I get to talk about our outpatient clinic, which I've really enjoyed being part of for the past few years. Next slide, please. As Dr. Kunisaki mentioned, we are a multidisciplinary team. So I've listed our members. I have pictures of us all. So actually, I realize I'm missing 2 physical therapists, but we have a really nice big team. We have a clinic coordinator, that's Ruth Gedichu, our clinic nurse, Jen Wilson. We have a neuropsychologist, occupational therapy, physical therapy, 2 physical therapists. We have a nutritionist, Stephanie. Dr. Joanna Burton is a pediatric neurologist who's part of our group. And then Dr. Peter McGazel, who is also the director of the Cystic Fibrosis Center here at Hopkins, is our pulmonologist. Dr. Kunisaki is our surgeon. I'm the cardiologist. And we also have a social worker, Inesita Burrell. Next slide, please. So I did want to spend a minute talking about Dr. Eric Jellin, who was really the one who brought us together into this outpatient clinic. He realized the need to have everybody in one place, and he realized how KKI, Kennedy Krieger Institute, could really combine some of this fantastic multidisciplinary care that encompasses neurodevelopmental pediatrics with all the Hopkins subspecialties that he then brought in. Dr. Jellin unexpectedly died. It's been almost a year in May 2021. I would imagine, I know a lot of you are parents here, and the mom and dad network in the CDH group is really strong. So I've loved that about working with you all, and you've probably either heard of him or met him. We got a letter one of the next mornings from one of the moms of one of our patients saying how she had heard the news of Dr. Jellin's passing and just wanted to express how grateful she was for our multi-D clinic. A lot of people have reached out. Next slide, please. So, with that kind of construct in mind, Dr. Jellin set about to combine the KKI forces with us. So Dr. McGazel, Kunisaki, and I are from primarily Johns Hopkins. And then Dr. Burton, our pediatric neurologist, she spans the 2. But the rest is a nicely kind of closely working team at KKI that we are part of. Next. One of the reasons that CDH really needs a multidisciplinary clinic. So this is a document. It's a very comprehensive post-discharge care from the American Academy of Pediatrics. It's actually due for an update now, but nonetheless, it's a great document, and it really goes into the ways that there are frequent complications. Pulmonary morbidity, pulmonary hypertension, swallow dysfunction, reflux, as Dr. Kunisaki was saying, growth failure, neurocognitive delay, hernia recurrence, orthopedic abnormalities, and other abnormalities that we help to screen for. And you can see I put 2 slides, 2 chest x-rays of babies here who actually had very severe CDH. They both required, one was a left-sided CDH, the other was a right-sided. They're both on ECMO in these pictures. You can see that the lung volumes are quite small. Next slide, please. But together as a team, we can really help bridge those gaps. And that's why I love being part of this team, because the sum is kind of greater than all the parts of different subspecialists trying to work together, but not as a group in one physical location. So the tests that we do at our clinic visits really do follow the survivorship guidelines. We screen for hernia recurrence, chest x-ray, echo, pulmonary function test as needed. We do developmental surveillance. We look for kind of orthopedic issues, scoliosis and pectus. Actually, by we, I mean Dr. Kunisaki, I don't. And then we also make sure that they're supported, that all the babies are getting Synagis when they should. Because for CDH babies, Synagis is a medication that helps prevent severe complications from respiratory syncytial virus, which can have very severe side effects in CDH babies. Next slide. So again, I was telling you, here are these comprehensive charts. You probably can't even read them because they're so crammed with information. But there's a very nice little intervals that are spelled out essentially from before discharge all the way up to about 18 months of age, and then often annually. But what you'll also notice is that there's a high frequency of the words if indicated, or if there were symptoms, or if previously abnormal. And that's where subspecialists really can help make that plan, make it together, make sure that your baby is getting to where they need to be, whether it's at Johns Hopkins, Kennedy Krieger, and often it is both, which is why it's a great location to be. Next slide. In terms of the screening we do, I had mentioned chest x-rays. We do a screening. This actually was a recurrence. You see the chest x-ray on the left-hand side. And this is not the first recurrence pickup x-ray, but it is one from hospitalization. And then just because I love echo, I had to put in a bunch of echo. And this is showing pulmonary hypertension, at least two of the slides in babies, and in older children too. And that is something we can pick up. Ultrasound echocardiograms are pretty frequently ordered. No radiation, bedside procedure. Next slide, please. I don't want to get too much into pulmonary hypertension. But again, having known CDH families, you all are a very educated group. You do a lot of research. And you will probably know that some of the more severe complications with CDH can be severe pulmonary hypertension. And those we've managed kind of from very mild cases, or essentially kind of normal lung pressures, all the way to very severe pulmonary hypertension as outpatients, even including up to a continuous infusion of a medication called treprostinil and other pulmonary vasodilators, which relax the lung pressure. Another great thing about having a multidisciplinary clinic is that I work very closely with our clinical pharmacologist from Hopkins, who helps set up all the weaning schedule, all the different medication schedules, which can be complex. Next slide. Okay, here's another of my favorite slides, because this is showing our echo lab. So children with CDH who are in our multi-D clinic often get their echocardiograms at Johns Hopkins the same day. So they'll get the echo at Johns Hopkins, go over to the outpatient center at KKI so they can have it all done in one day. We have child life specialists, and that is really wonderful for our clinic. And if you see here, I have two of our child life specialists. They have this little mini echo machine that they made, and they're showing a child what to expect for an echo. And here's our lead tech as well, doing an echo in our group. And then I'll be able to review those results with the family and sort of put it into perspective that same day. Next slide, please. And actually, congenital heart disease is a fairly frequent concurrent kind of finding in CDH, and can actually make up 2/3 of the associated abnormalities. So having a cardiologist, if I don't say so myself, is pretty handy. I can look at EKGs and help make sure we have all the resources we need. Next slide. Pulmonary comorbidity. So this is a major one, and this is the chest x-ray here. All the chest x-rays and everything I've shown are babies that we see in our clinic. So they're all outpatients. And they've all of these have done really just beautifully. Like Dr. Kunisaki mentioned, those small fragile lungs will grow and get stronger. But we do want to make sure that we're protecting them along the way. So about 25% of children will actually have obstructive airway disease. You can think of that like asthma at 5 years of age. And so we often do recommend pulmonary function testing. Dr. Magazel, again, is our pulmonologist. Here's a picture of the pulmonary function testing lab, which is right next to the echo lab, conveniently. And we also are monitoring for chronic lung disease. And then up to 50% of adult survivors will have abnormal lung function, but oftentimes this is managed just through ongoing care. So it's so important to get in early. Next slide, please. Growth failure, we have a nutritionist. She looks carefully at height and weight every time. And one of the major ways to really help the lungs heal and to promote alveolar growth is just really optimizing the calories. And oftentimes that'll mean some extra calorie fortification, oftentimes G-tubes. Next slide. Reflux is quite common, as was mentioned, and it does make sense. In terms of correlation with defect size and whether a patch repair is needed. And also children are at risk for not only refluxing, but then potentially aspirating. So again, lifelong surveillance here. But again, we also hook you up with those resources. Next slide. As I had mentioned, aspiration, here is a picture of a swallow study on one of our patients. We work really closely at making sure that the airway and the lungs are protected. And we do that through, there are multiple specialists both at Kennedy Krieger and at Johns Hopkins that we refer to on a regular basis, help order the tests and make sure that they're, really kind of evaluated in the context of your child's care. Next slide. We are so lucky to have a neurodevelopmental pediatrician. Dr. Joanna Burton is fantastic. And we also have a neuropsychologist as well, because neurocognitive delay and behavioral disorders can be common. And oftentimes this is in ECMO patients. So we follow all these sequelae and we follow them according to that comprehensive diagram I showed earlier. Next slide. So what we hope for the future is that we'll have some brochures. Actually, Ruth Getachew, who I had mentioned, had put these rough drafts out. We are happy to see patients at any time, basically from birth or older children, kind of more a consultant role. And I think perhaps I have one more slide. Oh, I don't. If not, would you mind putting me back to my first slide that has the picture of us all? Because I had a short story here to tell. Yeah, there we are. Thank you. So we had a young patient come in the other day and the mom was saying, I bet you wonder why I'm even here. She had her repair at a different center. And she didn't have a multidisciplinary clinic to go to. And the mom had always sort of had this fear, like, what am I missing? What am I following? Am I getting all the right services for my child? So it was just really gratifying to come in and sort of see what this mom must have seen through a consultant, like through the eyes of a parent when we have this team with all these resources. And she was so thankful, she said, from getting the medical records, which our clinic coordinator really went out of her way to do, to kind of very carefully going over the feeding and food aversion with our nutritionist, talking about potty training with our pediatric neurologist, and making sure she was really on track developmentally, making a plan for pulmonary function tests to come up in a couple of years, coordinated with an echocardiogram with me, and with Dr. Kunisaki telling this mom, your child had a type A defect. The chance that she's going to recur is so slim now. I mean, it was amazing to see how relieved she felt, and you could clearly see she was. I guess there's Dr. Magazel actually said it was kind of trauma from, he has a lot of experience working with CF patients in that regard, that this mom has gotten this diagnosis and didn't have that kind of overarching multidisciplinary care, and has just always worried ever since. So she also got to spend time with the social worker. So that actually helped too, to kind of talk some of these issues through. So I think we have a few different capacities to serve, and it's really been an honor to take care of these kids and their families. And that's all I got. Thank you.
Thank you, everyone. Thank you to our panelists. So we do have a few minutes here to answer a few of your questions. So I encourage you, to all our attendees, to submit your question into the Q&A box. Regardless of where you are on your CDH journey, our panelists are here to answer your questions. So our first question is a CDH diagnosis a sign of another issue or possible more complications down the line? And Dr. Baschat, did you want to answer this one? Oh, you're on mute.
I'm very polite, I always mute. Obviously, you know, we talked about a host of problems that can arise through life, you know, of a child with CDH. But I just start from a prenatal perspective. So it is our goal to examine the baby in the most detailed way that we can with ultrasound to find out if a CDH is an isolated defect or if other defects are there. Other birth defects are there. And so CDH is often isolated, right? The one other thing that can arise prenatally is that when babies have problems with swallowing, they can get increase in the amniotic fluid that can trigger preterm labor. So the other things that we focus on is if the swallowing mechanism works properly prenatally, and if there is an issue like that, we can manage that. So that's from a prenatal perspective. And so most babies really, it's an isolated defect, but it's our goal to find out if there are more things. And that's just from a prenatal.
Perfect, thank you. Our second question is, if I am not local, how can I pursue diagnostic treatment and after birth follow-up care?
Well, I just start again from prenatal and then hand it off to the pediatric colleagues. So all diaphragmatic hernias that want prenatal evaluation, that's all done in Johns Hopkins Center for Fetal Therapy. So that phone number and everything, that's all online. We see all the CDHs that get into the system prenatally. So I don't know if you want to say for postnatal patients that want to come after the baby has been delivered.
Sure. You know, I did put my I put my email address in there. You can reach out to me and I can get you other phone numbers. But we do certainly, I mean, we have the number for our clinic coordinator and for getting into KKI, like the multidisciplinary clinic. And then I think request an appointment, the numbers on the screen that you see now, pediatric cardiology, cardiac surgery, any of those can get you kind of in the door if you explain what you need.
Our next question is this condition genetic, and is it likely my future children will develop this?
So the genetics of congenital diaphragmatic hernia are pretty complicated, and there's also some ongoing research of finding, you know, the individual mutations that can lead to recurrent diaphragmatic hernia. Most of the babies, in fact, don't have any genetic abnormalities, but we offer genetic testing either prenatally or postnatally to all babies, because if there is a coexisting genetic defect based on what that is, there can be a recurrence risk and it can affect the baby's overall health. There are some families where we have identified genetic defects in the parents that led to recurrent CDHs in their children. But that's relatively rare. But one of the big advantages at Hopkins is we have a very, very sophisticated pediatric genetics service that can really hone into those kind of questions. And the discussions about it is certainly not something that we just do from a prenatal perspective. That is a discussion with many genetic experts that can counsel our patients about that.
Our next question is, what is your experience using vasopressin for pulmonary hypertension? And have you ever used this beyond an acute setting? And have you used it in a chronic setting?
So no, not typically. Usually what we use, you're probably familiar with nitric oxide just because of the quick on and off. And then we will sometimes use the drips I was talking about, the prostacyclin analogs. And anything that's a continuous infusion is really hard to use in the chronic setting. But nonetheless, as I had mentioned, we have done it with treprostinil, subcutaneous continuous infusion. So that's really the chronic setting. And then there is an inhaled medication called Flolan. It's another prostacyclin type of medication that's used to kind of really relax the pulmonary vasculature. We try, once patients are outpatient, to rely on the oral medication and just inhaled oxygen. Inhaled oxygen is a very potent pulmonary vasodilator, but try to get the kiddos off the supplemental cannula as soon as we can, so they're not tethered.
Our next question is, how do you treat refractory pulmonary hypertension? Is this something you would expect to follow a patient for years in cases with very small lung volumes?
You know, that's a great question. Refractory pulmonary hypertension, luckily in CDH, a lot of what we see is the alveoli do continue, the lungs continue to grow and heal for 6 to 8 years of life. So oftentimes, if we have enough time of stability and protection of the lungs from aspiration and pulmonary vasodilation, oftentimes it's not refractory, but in the cases that are, we often do multiple pulmonary vasodilators, longer term inhaled just supplemental oxygen, and sometimes that subcutaneous treprostinil. That's really our kind of our armamentarium for treating pulmonary hypertension. Now, the small lung volumes, this is very interesting to me because, and this is why it's great to have a pulmonologist in our CDH group. Patients with very small lung volume on one side don't always have pulmonary hypertension long term because the other side after repair grows nicely. And so we don't always see it just with pulmonary hypoplasia, but it's absolutely important to have a pulmonologist with us to make sure that we're treating any reactive airway disease, anything with albuterol, flow vent, like inhaled pulmonary therapies, and then we work together with diuretics. So it's a balancing act, but that won't necessarily, even if you have very small volume lung at one time, oftentimes it does get better.
Our next question is, what do you consider to be the best indicator for how a baby with CDH will do after birth?
I don't know if that's a prenatal question, but I'll start from prenatal. So how a baby with CDH will do after birth depends actually on a number of factors, and that's our goal to, check as many positives as we can. So it starts with the severity of the hernia, the lung size, the size of the side of the hernia, and any other issues prenatally that might contribute for the baby to deliver prematurely. And for babies that are candidates for fetal therapy, our huge goal is always to make sure that the baby delivers at term. Because what you want to do is you want to preserve all the treatment options that exist for a baby with a CDH so that they can have a better start. And some babies may be too small to receive ECMO if they need it, for example. So it's a number of things that could play into that. And that's one of the things that we discuss in detail with our parents, and that's relatively individualized as well.
Our next question is, what is the exit to ECMO birth plan?
So exit to ECMO is whenever we are worried about a baby's airway and that we would have difficulty placing a breathing tube after babies are born, we will offer ECMO while the baby is transitioning from being delivered, usually by a C-section and still connected to the placenta. And then we will still perform the same procedure of ECMO while the baby is still being supported by mom through the placenta. For babies with CDH, this is not typically required. Oftentimes, babies will have normal airways, facilitating us to be able to deliver them using standard methods and being able to intubate them and provide ECMO later if needed.
Another rationale for exit to ECMO, at least in theory, was if you knew that a baby's lungs were so severe that for sure they would need to be on ECMO soon after birth, why not do this from the start to protect the lungs and to resuscitate and support the baby while on ECMO to give the best chance for survival. I think most major centers, at least, have abandoned exit to ECMO as a strategy, largely because most of the experience based on both mortality as well as chronic problems, so morbidities, there really has not really been shown to be any added benefit to exit to ECMO. Plus, it places extra maternal risk because it requires uterine relaxation and at least an increased theoretical risk of bleeding. And so the exit to ECMO strategy generally is not, I would say, standard of care at most places. For the very severe CDHs that we've identified prenatally, most centers, including Johns Hopkins, have really adopted a strategy where we just have ECMO readily available at the time of delivery through a very coordinated effort with the Center for Fetal Therapy, so that we're able to place a baby on ECMO within the first hour or two of birth. So we can utilize most of the theoretical benefits of exit to ECMO without placing the burden in terms of maternal risk.
Our next question is, what is low risk CDH, and can low risk not need fetal therapy treatment?
Yeah, so fetal therapy treatment is reserved for severe hernia. So that means babies where the lung size is less than a quarter than what is expected. So we consider mild CDH if the lung size is over 45% and moderate size between 35 to 45. So that's basically in just based on the lung size. And other things that fall into risk assessment is if there are other physical abnormalities. I don't know if you wanted to add anything from a postnatal, but that's what we basically counsel the patients on in terms of severity.
No, I agree with Dr. Baschat's comments. I mean, the majority of CDHs, certainly 80% plus, do not need any fetal therapy per se, and can be managed postnatally with generally very good outcomes. Most low-risk CDHs are typically identified not only by lung size on ultrasound, but also typically do not have liver herniation. And so those are really a distinct group that tend to have a much better prognosis in terms of disease severity.
Our next question is, do standard prenatal scans detect a risk for CDH, or do I need to ask for additional scans?
So all pregnant women really should have a first trimester ultrasound and then the detailed anatomy ultrasound. That's typically done between 18 to 20 weeks. And if that's done in a place that basically runs a prenatal diagnostic service, so either a maternal fetal medicine practice or an experienced obstetrics practice or an experienced radiology practice, the views that you are supposed to obtain will show a diaphragmatic hernia at that scan. There is no special scan required. If the anatomy scan is incomplete, particularly of the thorax, then one option is to go for a second opinion or repeat the scan within a short period of time. But the reality is that most severe diaphragmatic hernias are really identified at the 20-week anatomy ultrasound.
Our next question is, how do you treat a problem with ventilator perfusion mismatch, even if all the treatments still lead to low saturations on 100% oxygen? Is time to grow the lungs the only thing that can help this?
Dr. Garcia had mentioned moving from conventional ventilation to oscillating vent. And we try kind of an escalating type of medication, starting with 100% FiO2, and then we end up with nitric and the prostacyclins. And then sometimes when that fails or things have just progressed too rapidly, ECMO.
Looks like we have time for one more question, and that question is, what causes infant fluid retention and the need for diuretics when the heart is deemed healthy and functioning properly?
Sure. So when we put babies on pulmonary vasodilator medication, it does kind of cause extra blood flow to the lungs, and sometimes that fluid can kind of transudate and have some pulmonary edema. And then also all babies, when they're first born, they have a couple kind of normal fetal shunts, a little hole in the heart called a patent foramen ovale, and then another fetal blood vessel that's often still open called the ductus arteriosus. Both of those can lead to a little extra flow to the lungs. So that's one reason, normal healthy heart. The other reason is pulmonary hypoplasia. And so if you have a small lung and kind of chronic lung disease, sometimes just that extra amount of diuretic therapy can be helpful, even if the heart is completely structurally normal. So it's kind of that's why it's so nice that we get to work together, the pulmonologist and I, because I can ask him, are these diuretics for chronic lung disease? And he'll say no. He'll say, do you need them from a cardiac perspective? No. Sometimes you'll see like people will go back and forth. Oh, it's the heart, it's the lungs, but we don't have to worry about that. But it's pretty common therapy, at least until we're off oxygen and pulmonary vasodilators, to continue a very kind of low dose diuretic.
I will just add that after surgery, oftentimes babies will become very swollen from having extra fluid, and that's not uncommon. If they are not on ECMO during the surgery, we can often use medications to remove that fluid after surgery. If they are on ECMO, then we'll use the ECMO circuit to remove that extra fluid. But mostly, this will resolve itself a few days after surgery.
Oh, that is such a good point, Alex. I mean, probably almost every baby who needs ECMO at some point is going to have some fluid balance that needs to be resolved. Yeah, that's a little bit different from the long-term diuretic. Yeah.
Well, we thank everyone for joining today, and we thank all of our experts today for that very great presentation. If you missed parts of our presentation today, a recording will be emailed out to all of you in the next day or so. And we also encourage you to fill out the survey following this presentation. If you would like to schedule a consultation, you can also provide your contact information in that follow-up survey. We thank everyone for joining, and we hope you have a great evening.
Thank you.